Okay, can I just, before starting, can I just ask everyone to kindly mute their videos? So it's 2:35, I think we'll make a start. Hello and welcome to this first in a series of teaching sessions called Cardiology Video Teaching During the COVID Pandemic. I'm Vishal. I'm a cardiology ST7 EP and device trainee at the Hammersmith site, and I'll be teaching on SVTs for the general cardiologist, ECGs and treatment tips. Now, Professor Francis had been keen that we continue to have some form of direct cardiology teaching during this COVID pandemic. And to that end, we've devised a program which is just been set up. And I'm grateful to Chris Cook, who's volunteered to do the next session for Tavi, for the general cardiologist, and Saeed Gardezi, who will be doing advanced heart failure, mechanical circulatory support and transplant for the general cardiologist. And to Brian Halliday, who's going to be doing on dilated cardiomyopathy, genetics and risk stratification. If you are interested in volunteering, then please, by all means, email me or later my colleague Balric, and we can devise you onto the program. We're looking to run about 2 of these sessions per week. A little bit of housekeeping. I mentioned at the beginning, can I ask again, could all participants please mute? Could all participants please mute? So this is 40 minutes. I have to stick to time, otherwise Zoom will cut out. I'll kind of aim to do about 30 minutes of presentation and about 5 to 10 minutes of questions. If you have any questions, please write on the chat or raise your hand. We'll address them at the end. Just to kind of create this into a formal program, we thought it'd be sensible to create a survey monkey where we'd have feedback. For each subsequent session, you will also have a link to complete feedback on the prior session. The link there is going to be for this. And if you're interested in having attendance certificates for attending here for ARCP or whatnot, then please by all means email Balric Cayley to help with that. We will record this. I've pressed the record button and hopefully it's working, with a view to creating a private YouTube channel and sharing this. So just to continue straight on. So I'm going to be talking about SVTs, and I promise there will be no EP traces. There will be no EP mechanisms. The objective of this is purely to talk about ECGs and the lessons that I've learned over my times as an EP fellow. I've been doing EP since 2014, and I hope to share some of the nuances that I've learned over this period of time. We'll be talking about focal atrial tachycardias. Remember, this is a focal origin coming from somewhere within the atria. We're talking about CTI-dependent flutter. Here it's a counterclockwise circuit within the right atrium, AV-NRT, and AVRT. So to move straight on, this is atrial tachycardia. Now, the reason I'm showing this particular ECG is because I think many people, including many cardiologists, might be fooled into thinking that this is sinus rhythm. And the reason, what I've learned from this ECG, and I do in my regular practice, is look at V1, V2. I think V1 and V2 are incredibly valuable into trying to understand what's happening in the atria. Remember that these are 2 channels which are directly overlying the right atrial appendage, which is effectively a cul-de-sac, where activation within the atria kind of comes to a point and then cannot move anywhere. So it gives you a very telescopic bird's eye view of exactly what's happening within the atria. Now, if you look at V1, V2, and it's good to have this in your kind of assessment process, you can see that there's this additional blip inside the T wave. This is a P wave buried inside this T wave of a patient who's got a 2-to-1 atrial tachycardia. And this occurred as a consequence of prior atrial fibrillation ablation and scar delivered from ablation, generating atrial tachycardia. These type of atrial tachycardias are by far best treated with catheter ablation. Cardioversion only just temporizes it for a short period of time. Drugs are very hard to rate control these things. And catheter ablation is usually very effective. With the current nuances with 3D mapping that we now have, this can be terminated and cured moving forward. Now, in this strip, many of you would look at this and think that this is sinus tachycardia. I think it's very reasonable to do so. You have a regular, narrow complex tachycardia where there are P waves preceding every QRS, and the axis of the P wave looks just like sinus. Now, if you looked at this in isolation, you would recommend that this is sinus tachycardia, and the physician look for the secondary causes, sepsis, hypovolemia, bleeding, whatnot. But what's invaluable is knowing that there are some forms of atrial tachycardia which live very close to the sinus node, and in fact can create the P wave morphology of a sinus tachycardia. These are called sinus nodal reentrant tachycardias and focal atrial tachycardias arising close to the sinus node, just above the superior crista terminalis. The reason I like this ECG is because it makes you realize that there are these additional tachycardias, which I think general cardiology should be aware of. And the only way you'll really be able to diagnose it is by seeing the onset of or termination. It is only with the onset, i.e. seeing a sudden change from a heart rate of 60 beats per minute to 130 beats per minute, or a sudden offset from 130 beats per minute back to 60 beats per minute, where you're able to recognize that this is atrial tachycardia as opposed to sinus tachycardia. Now, let's move straight on to atrial flutter. I'd like to present a case. So this is a chap who's 40. He gets admitted to A&E. He's got a history of paroxysmal atrial fibrillation, and he takes flecainide, 50 milligrams twice a day. He's presented with an acute onset of palpitations, and he's normotensive. And this is his ECG. How would I describe this? I see a regular, narrow, complex tachycardia, where I'd say the heart rate is around about 200 or so, 220 beats per minute. Now, in this, it's very hard to diagnose which type of SVT he has. And there are various possible differentials. Now, looking at that little cartoon I showed at the beginning, he's a young chap and he has a history of atrial fibrillation. We know that young patients with AF often have an underlying SVT substrate, the AVNRT or AVRT. And we would usually recommend doing an EP study purely to look for this additional substrate in patients with atrial fibrillation. So this could be AVNRT or AVRT. Now we know he's on flecainide, and flecainide can organize atrial fibrillation into a regular atrial tachycardia, i.e. something like this. So it could be that he has an atrial tachycardia with one-to-one conduction. But the real learning point from this ECG is the role of flecainide on the atrial rate in flutter. And I really, really want all trainees to understand this. Flecainide, so atrial flutter has an atrial rate, i.e. the time it takes to go around the right atrium, of around about 250 to 330 beats per minute. That's normal. Now, normally, the AV node cannot conduct that sort of atrial rate with one-to-one conduction. It's just too fast. So it usually blocks every other beat, resulting in 2-to-1 AV block. And that's why we're so familiar at looking at typical atrial flutter with 2-to-1 conduction with a heart rate of about 150 beats per minute. That's very common, and I'm sure you've all seen it. Now, the problem is that when you give patients flecainide or other antiarrhythmics like amiodarone, in addition to slowing conduction in the AV node, the important thing that these drugs do is they slow the cycle length, or that in simple man's terms, it slows the time it takes for the rotation around the right atrium. So rather than going round at about 250 to 330 beats per minute, it can go around about 200 to 220 beats per minute. So flecainide has slowed the time it takes for that circuit to go round. The problem with that is that once the atrial rate has slowed, the AV node might then be able to conduct that slower atrial rate with one-to-one conduction, resulting in a paradoxically higher ventricular rate. So the learning point is, and I'll tell you that this ECG was in fact atrial flutter with one-to-one conduction, is that patients who have a history of atrial arrhythmia, and that's AFib, ATAC, or particularly AFib and AFlutter, the key ones, if they are on regular flecainide, one should recommend that they take the flecainide after taking a nodal blocking agent like bisoprolol. First take a beta blocker, wait for that degree of AV nodal block, and then take the antiarrhythmic to prevent one-to-one conduction. I hope that's clear. Now, in essence, when a patient presents to hospital in this ECG, we all know the first thing we would be looking for is some form of vagal maneuver, carotid sinus massage, or adenosine. And I wanted to talk about the effect of adenosine in these tachycardias. When you have a patient who is delivered adenosine and nothing happens, there is one of two things. It's either that it's actually VT, or far, far more common is that you've just not given enough dose. Now, all our textbooks teach us 6-6-12 or 6-12-12. Now, in the EP lab, we routinely start off with 18 milligrams. And in my experience on the in acute admissions, I've given up to 24 milligrams. So I don't say that you should start that routinely, but I say that so that you do not be fearful of giving higher doses of adenosine. Now, how do you know how much adenosine is enough? The way I make a judgment is if it has had no perturbation on the ECG, if there has been some symptomatic effect on the patient, i.e. he felt some tightness in the chest, some breathlessness, he felt rough, it felt rotten, then you've probably had an appropriate dose. And then it's reasonable to stop at that particular point. Now, here's that same scenario of that chap, and I've just changed a few of the words. So now, rather than him going to A&E, he's actually come directly to you, the cardiology specialist, via the London Ambulance Service. This is a primary arrhythmia call via the LAS with a broad complex tachycardia. So I've changed a couple of the things. He's still 40. He's now very symptomatic paroxysmal AFib. And he's now, rather than on 50 milligrams BD, he's on flecainide 150 milligrams BD. And his palpitations, he's come in, but they're definitely worse than normal. But his blood pressure is still reasonable. Now, when you're faced with any patient with a broad complex tachycardia, there are three diagnoses you must consider. It is either VT, it's an SVT with aberrant conduction, or it's pre-excited atrial tachycardia. And here's his ECG. Now let's take a moment to have a look at this. You have a regular, broad complex tachycardia. Whenever you see a regular broad complex tachycardia, the first thing I do is try and work out, is it what we call a left bundle branch type or a right bundle branch type? We're not saying that there's actually any block anywhere. We're just calling it by its inverted commas type. And the reason why we type things is it gives us further clues as how we're going to try and work out which type of, is it VT or SVT? So this is a left bundle branch block type. Why? Because we just look at V1. V1, the axis is pointing down. We know in right bundle, V1, the axis usually points up. Therefore, this is a left bundle branch type of broad complex tachycardia. That's the first thing. Now, the next thing is we look at concordance. And here in the precordial leads, we see that there's complete negative concordance. So this would suggest that this patient has VT. And indeed, there are lots of algorithms out there to try to help one diagnose SVT versus VT. Now, if we follow this chap, he does not have any AV dissociation. There are no capture or fusion beats. He does have negative concordance. And his QRS is pretty broad. I'm not quite sure it's up to 160, but it's pretty close. So it certainly smells like VT. But remember, these algorithms are just algorithms, and I propose this to you to say that algorithms are not absolute. They are just, as they are, algorithms. And the key thing that this patient had was a tolerable blood pressure. If this chap presented to us, to me, at the heart attack center at the Hammersmith Hospital, very first thing I'd be doing is giving him you could either do a neck massage, vagal maneuvers, or what I would be doing is giving him adenosine. And many people might say, well, he's a regular broad complex tachycardia. It looks like VT. We need to treat it as VT. In this particular case, This is actually a publication from Europace. They gave it a carotid sinus massage. What you immediately see is after the delivery of carotid sinus massage is an immediate perturbation of this rapid broad complex rhythm into a narrow complex rhythm. If we look at the inferior leads here, 2, 3, and AVF lower down, you can see that there's the appearance of a sawtooth P wave. Looks like a flutter wave. Now, it could be that this patient has what we call dual tachycardia, i.e. VT, and he has flutter. Or it may be, and it was the case in this situation, that this chap actually just has typical flutter with one-to-one conduction and a broadening of the QRS, partly from left bundle branch block aberrancy, and also from fleconide. We know that patients with fleconide can get very strange looking QRS morphologies. And another differential for this patient is that. So this is after restoration of that broad complex rhythm, you see he's clearly got this flutter wave. So the learning point for me is that tolerated broad complex tachycardias, adenosine is just invaluable to the immediate and long-term management. Let's say you didn't give this chap adenosine. Let's say, and you wouldn't be poo-pooed. Let's say you gave him, you cardioverted him because you're worried about whatever. It's really hard to know what this is. And I think on balance, you'd have to say this was VT. And he would have to have a cardiac MRI to look to see if there's any underlying substrate to allow him to have VT. He'd probably have to have a coronary angiogram. He'd probably have, I'm going to assume all of this is going to be normal. He'd probably have to have some form of EP study with a VT stim. And there may or may not end up being discussions about an ICD. So to save certainly the EP doctors an incredible amount of time, adenosine is an invaluable tool when administered safely to help differentiate these complex arrhythms, when otherwise, if I were to honestly look at this story, I'd be very surprised if this patient presented with VT. Yes, we know fleconide can cause VT, but in general, my hunch would be that this would be typical flutter with one-to-one conduction conducted aberrantly. I hope that I've gone into detail on that, but I've seen a number of cases just like this. And I think for general cardiologists, knowing this particular presentation, especially as we're now very aggressive with atrial fibrillation patients, giving them high dose antiarrhythmics, referring them for catheter ablation, being aware of this presentation is really important. Okay, AVNRT. For me, AVNRT can be diagnosed by everyone on an ECG. AVNRT can be diagnosed by everyone on an ECG. Let's just have a look at this. Here you see an ECG of a regular, narrow, complex tachycardia. Now, the way you can diagnose AVNRT is by comparing the SVT ECG to that in sinus rhythm. Here's before, here's after. One more time, before, after. What I want you to focus on is V1, lead 2. Look at V1. Here in sinus rhythm, we have a P wave, a QRS complex, and a T wave. But in AVNRT, we don't clearly see a P wave. We see a QRS complex and this blip, this little bulge, which is very fixed. This here is called a pseudo R prime, is the technical EP term. But what it actually is a retrograde P wave coming from the slow, fast, short circuit in AVNRT, coming back up to the atria. Now, in lead 2, team, whoever's just joined, can I kindly ask them to mute? I'll be very grateful. Now, looking at lead 2, here you see a negative deflection. And that's because lead 2 looks at the bottom of the heart where this originates, the bottom of the atria, excuse me, where this originates. Now, we call AVNRT a short RP tachycardia. Why? Because the circuit rotates just close to the AV node. It goes up to the atria and down to the ventricle almost simultaneously, giving you this fused QRS and P wave complex. So one more time, let's have a look at that. Look at V1, you see that blip, and look at lead 2, you see that negative blip, and there you see it's gone. That ECG is characteristic of AVNRT. And I think it's really important to be able to diagnose it because AVNRT is really straightforward for the electrophysiologist to treat. And we strongly advocate treatment of this condition because it is curative. This is not like AF ablation where you have to come back and back and back. This is a one-stop, on the table, 1 to 1.5 hour procedure, diagnosis, treatment, cure, off medications for the rest of your life. So it's really valuable being able to recognize this and referring it on to the appropriate person. Now, there are challenges, and this is AVNRT, but this doesn't look as easy as what we saw before. Here we see a regular broad complex tachycardia. As we saw before, this could be VT, this could be SVT with aberrancy, or this could be pre-excited AVRT, excuse me. Now, when you're faced with a broad complex tachycardia, we have to go through that algorithm again. Here you've got a regular broad complex tachycardia, and this is a right bundle branch type. When you have a right bundle branch type, there are various different paths to the algorithm. How broad is it is one of the things we look at. But I have to say, one of the things I really like is what's called the rabbit ear. And I use this really regularly. The rabbit ear is really helpful to differentiate SVT with right bundle aberrancy and VT. And I've got 2 cases to illustrate. This patient had SVT with right bundle branch aberrancy. Now, what do I mean by the rabbit ear? Now, we know in right bundle branch block, there is an RSR pattern. And in right bundle branch block, you have a small R wave followed by a big R wave. And if you look at V1, V2, you have this little small R wave, then the S, and the big R wave. This is the characteristic morphology of right bundle branch block from an atrial-based arrhythmia. Now, this is VT, where it's a big R wave followed by a small R wave. So I actually remember them as rabbit ears. So in SVT, the left rabbit ear is smaller than the right rabbit ear. And in VT, the left rabbit ear is bigger than the right rabbit ear. Here's someone with VT. Now, look at this. This ECG is almost identical to this ECG. Look at the axis. It's identical. This is impossible to differentiate how you're meant to pick up between one and the other. But I know the answers because they both had EP studies. And the only clue that I can pick up to help me in diagnosing this is that in this SVT, the left rabbit ear is smaller than the right rabbit ear. And in this VT, the left rabbit ear is bigger than the right rabbit ear. And I think the rabbit ear, which is now, if you even look at the actual published guidance when it comes to, from Wellens, they even quote the concept rabbit ear up over here. So I think it's a useful tool to help differentiate between the two. Now it's important to be able to see that for this ECG. Have a moment to have a look at this ECG. Here we have a regular, broadish, complex tachycardia. It is right bundle branch type. There is a left axis deviation. Now, this is difficult. This could be an SVT with right bundle branch aberrancy. It could be an atrial tachycardia. It's a bit too slow for AVNRT or AVRT. Or this could be VT, but it doesn't look like your typical VT, I must say. So, of course, we're lucky in this particular tracing, but we don't usually get so lucky. Here, we can see a capture beat, consistent with this being VT. And we see these dissociated P waves, which are conducting through fairly regularly, independent of the QRS activity. But we see this QRS morphology here. And this looks pretty narrow. This is what we call fascicular VT. And it's a very spot recognition ECG. This came up about 3 times a few years ago when I did my KBA exam. This particular ECG, fascicular VT, right bundle, left axis, and you get lucky if you see this dissociation or a capture or a fusion beat. But here again, you kind of see that rabbit ear again pattern as well. Now, the importance about fascicular VT is that this is treated with verapamil. It's a verapamil sensitive tachycardia. This is unlike and does not respond to adenosine. So adenosine, again, is absolutely helpful in this particular trace. And finally, I want to talk about AVRT. Imagine this scenario, a 25-year-old man who presents with recurrent palpitations. He's never had syncope, and he's had no arrhythmia documented in the past. Now, he's a primary arrhythmia call to you via the London Ambulance Service because he was pre-syncopal with this ECG. And this ECG is a never miss ECG. This ECG shows a irregular, broad, complex tachycardia. Now, this is either ventricular fibrillation, but in this particular scenario is atrial fibrillation with pre-excitation. Notice how you have the appearance of delta waves in V3 to help you. And as you follow the rhythm strip, there are some complexes where you're like, it's not so obvious a delta. And then you have complexes where there's a very obvious delta. This is typical. If you imagine in atrial fibrillation, sometimes you're having what we call fusion between conduction via the AV node from the atria or conduction via the accessory pathway. And the key learning point about this ECG is that this is one of the arrhythmia emergencies. And you must not give any form of AV nodal blocking agents for this particular arrhythmia. So just to be clear, you've got atrial fibrillation with a rapid atrial rhythm conducting rapidly down the pathway as well as fusion with the AV node. If you completely block conduction in the AV node, you've got complete conduction via the accessory pathway, which inadvertently could result in ventricular fibrillation. Now, in my experience, I've seen this 3 or 4 times, and in general, when I've seen it like this, I've recommended emergency cardioversion. Because they have atrial fibrillation, you should give them heparin as a treatment shot, and usually you know the time of onset. But according to guidelines, if they're stable, it is reasonable to give them flecainide as well. Now, from an EP perspective, what we're looking for is what is the shortest R to R interval. In what we use is if it's a cutoff more than 240 beats per minute, this is defined as an unsafe arrhythmia and mandates catheter ablation. But from your perspective, anyone with pre-excited atrial fibrillation should be considered for inpatient catheter ablation. Now, what's incredible about this ECG is the subsequent potential ECG. This is a patient who has atrial fibrillation. Whilst I'm not going to go into where the pathway is, let me tell you that this is a left lateral pathway. We know that because it's a positive delta in the inferior leads and positive in V1, V2. Remember, these are looking at the right side, activations going to the left side from here. Now look at the same patient, this patient's ECG. This patient had a left lateral accessory pathway. And look how difficult it is to see any form of pre-excitation. I often get asked in consults about, Vish, do you think that this patient has a pathway? And my answer is usually, I don't know. Because you cannot exclude a left lateral accessory pathway from the ECG alone. Look at how difficult it is. There's a suggestion of pre-excitation from the short P to QRS interval here, but it's very difficult. Why does this happen? Well, we know in this rhythm, the patient's atrial activation starting in the sinus node. Sinus node, this is the right atrium, this is the left atrium. The sinus node is somewhere around here. Now, a left lateral accessory pathway lives all the way over here. So when atrial activation comes across the atria, there's fusion between it going via the his down to the ventricle and coming all the way across to get to the left lateral pathway to get to the ventricle. And by the time activation has reached this left lateral pathway, almost all of it has gone down the AV node. So you do not see any significant evidence of pre-excitation. So the learning point from this ECG is that it's very difficult to diagnose. You cannot say that this patient does not have pre-excitation based on an ECG alone. When there's an index of suspicion, then speak to an EP and they may consider doing the following. One, a Holter monitor, because we know at nighttime you get changes in your vagal tone, or in the daytime you may get changes in your vagal tone, which may result in preferential block in the AV node and conduction down the pathway, making it more obvious that someone has pre-excitation. Or alternatively, they may suggest an adenosine challenge to see if there is any evidence of what we call manifest pre-excitation. The terminology for this ECG would be called latent pre-excitation. Latent because you can't quite see it. The last thing I want to say before wrapping up is the value of having documentation. Documentation is imperative because without it, we don't know what we're dealing with. And Alive Cores and Apple Watches are revolutionizing our approach to documentation. This was a chap who was referred to Norman Qureshi in High Wycombe a couple of months ago. And I sent this as a tweet, and it's just an incredible image. This was a chap who had palpitations pre-syncope, and at the time of symptoms, recorded it on his Apple Watch. And if you can see here, this patient has atrial fibrillation by this irregular activity and pre-excitation, with a very short R-to-R interval consisting with an unsafe pathway. As soon as we had this evidence, he was admitted to hospital and transferred to us directly for inpatient catheter ablation. So that was a fairly whistle-stop tour of learning points from ECGs in SVTs, and I hope you've all found that fairly useful. I think we've probably got about 3-4 minutes where I'm happy to address any questions, if I can work out how this... Are there any questions?
Thanks, Vish. It's Praveen here. Really amazing teaching. I've had patients in clinic with a short PR interval, but nothing else obvious on their ECG. What do I do with that situation?
Yeah, so
what do I look for? What do I do?
So I think the first thing is you're trying to determine symptomatology. So if your index of suspicion is high, i.e. they have regular palpitations or there's any dizziness, blacking out, I mean, you have to err on the side of caution. So I'm going to assume your question, this patient has no symptoms. So if they have symptoms, you may, if it's convincing, you may speak to an EP and refer them anyway for an EP, for EP opinion plus minus EPS. If they have absolutely no symptoms, then the next thing would be is to do a Holter. Because a Holter, as I say, can demonstrate periods, because of changes in vagal tone, you may then preferentially get conduction down a pathway, which is very far away from the AV node, and during the course of the day or nighttime. And if you're still concerned, it's reasonable to have a discussion with EP to consider an adenosine challenge. So we do this, we invite patients to come to hospital as a day case procedure. They get onto the table or they do it in the day ward. You give them a slug of adenosine and you see if there's any change in QRS. Chris, I hope that's helpful, Pervez. And
yep,
Chris,
thank you.
No worries. Chris, I see there's a question.
Hi, mate. Thanks very much. Fantastic. Just for us generalists, when do you use link devices in your clinical practice?
Okay, so for me, if someone has palpitations, that should be picked up with some form of telemonitoring, i.e. iPhones, Alive Cores, Apple Watches, they're fantastic. Links are for syncope. Pre-syncope, syncope is generally the time when I'd be going down that pathway. Now at Imperial, we're blessed by the Imperial Syncope unit, who, to be honest, I think they're the world-renowned unit. Certainly, really famous within the UK. But we're blessed to have their expertise in taking a really careful history about pre-syncope, syncope, and guiding people on appropriate pathways. But to answer Chris, if it's palpitations, I tend to go down some form of monitoring, which is by phone-based. And if it's pre-syncope, syncope, then you can have a device.
Thanks, mate.
Any other questions? We have exactly 1 minute left, I think, before my 40 minutes wraps up. I hope that was helpful.
I've got a question. Can you hear me? Sorry.
Yeah.
Zach. Hi.
Oh, hey, Zach.
Sorry,
Zach, just quickly, before you do, so just remember, guys, Juliet will send a message out to everyone for the next talk, which will be next week, Tuesday. Chris Cook, who's an interventional fellow, and we're talking on TAVIs, and that will be next Tuesday, and we'll keep this going. And if you do want to volunteer to take part, then please, by all means, email me. Zach, your question.
Hi, sorry, I may have missed, well, I have missed some of the talk, so I apologize if you've already covered this, but just really to ask about the role of adenosine in stable, broad complex tachycardias.
Yes.
The first presentation where you're not, where you don't really have a clear etiology, or you know, it could be any of the three well-recognized causes of a broad complex tachycardia. What do you think?
Absolutely. I mean, my practice, if you've got a regular broad complex tachycardia and you have a window to give them adenosine, it's invaluable. I cannot stress the value of it. I say that as an ALS instructor, where it's the complete opposite. But as an EP person, I think it's really valuable to have it because, first of all, you see so much information. It helps you with your diagnosis. It's so unnerving when you have to make a decision about an ICD in someone where you're basing it purely on the ECG. And then you have to judge it on pretest probability, LV impairment, coronary disease, scar, the whatnot. But you have these bizarre cases where there are patients who do have normal heart VT. Normal heart VT is usually something we can treat with catheter ablation. But if they've had syncope with it, then you're into this realm of different of challenges in what you need to do next. But my own experience, and I know that from the EP consultants with us, is it's invaluable to have adenosine and to give a dose that makes the patient aware of it. If the patient said, oh gosh, I felt absolutely fine, doctor, it's unlikely you've given them an effective dose. Now, it sometimes can happen, you know, when they've been in tachycardia for a long period of time, their blood pressure falls, you give them a slug of adenosine with a peripheral flush. If you've done it through a blue in the blue venflon in your hand, they may not have got an appropriate dose, and therefore you're being misled. You need a wide bore access in the antecubital fossa with a large flush to make sure that you've given an appropriate dose. And as I say, don't be frightened to give a higher dose than what you might normally do. I have to say, Zoom is great. It's continuing this. I thought it was going to cut us out in 40 minutes. So if there's more questions, by all means.
Tiniest thing. So, and is this still the principle that you use if it's somebody with, for example, a background of previous bypass and who's got a monomorphic VT and you've got LV impairment, and you're pretty sure it may well be scar related? If it's the first time and they're stable, would you still do an adenosine challenge?
So me, I would. I think others may feel less comfortable. I do that with an EP hat on. And I know that because if this chap does genuinely, if the ECG is absolutely clear cut, and I showed Zach the ECG pattern of the Wellens criteria, if it's very clear to me as an EP that I think this is VT, then perhaps not. But if it's actually SVT and you go on and put a defibrillator in, he may well end up having inappropriate therapies moving forward. So it's helpful. As long as it's not a contraindication, as long as you don't think you're going to make that patient worse. So they're not asthmatic, they're not hypotensive, that you're not worried that they're in an extremis where adenosine may be a problem. Now, of course, when you give adenosine, be mindful that you should have pads on because adenosine can destabilize an arrhythmia to result in ventricular arrhythmia. It can induce atrial fibrillation. It can result in very long pauses. So you have to be prepared and comfortable for the aftermath of giving the adenosine, but it's an invaluable tool for all of us in terms of making the subsequent decisions for that patient. Any other questions?
Thank you.
Vish, thanks so much. In one of the ECGs you said with the rabbit ears, one was one where you're showing in V2 you had the rabbit ear pattern, but in V1 it showed actually the opposite.
I was wondering if anyone would say that. Yeah, no. Remember, I think the reason I'm glad you raised that because algorithms are algorithms. Algorithms are algorithms. They're not the truth. They're there to guide us, but they never really lead us to the truth. And that's the challenge with these broad complex arrhythmias. That's why adenosine is so helpful because you get unmasking of A and V to help guide your decision making. So you're absolutely right. V1, it looked like a typical right bundle, whereas in V2, it looked more like the VT pattern. And it is what it is. I would be giving adenosine.
Yeah, no, definitely. Okay, yeah, great, thanks.
Always, of course, remember there's an EP consultant on wherever you are in specialist hospitals. If you're from DGHs, there may not be, but I think there's, especially in the tertiary centers, an EP consultant. They're always really nice and willing to discuss these cases. I know from experience there's a general encouragement to give adenosine because the subsequent decision making is so much more helpful. But of course, as long as the patient is stable. If the patient's unstable, then you just go down the advanced life support pathway.
Thanks,
Any other questions? Tiffany. Oh, yes. Okay, thanks. No worries. Thanks, Tiffany. Okay, so I'm going to wrap this up then, because I think part of the good thing about this is keeping it to time so it's concise. And then we have these regular snippets. As I say, I'm really keen for others to volunteer. So obviously I'm EP, so I'm happy to talk about this. But I'd love to hear, for even myself, about all the other subspecialties. And even if you're just a ST3 to ST5, if there's something that interests you and you think others would want to hear about it, an interesting endocarditis case or whatever you'd like to talk about, we seem to sadly have quite a lot of time now where it would be valuable to fill our brains with some regular cardiology teaching moving forward. And Professor Francis is very keen to advocate that too. All right, if there's no further questions, I'm now going to stop the recording.